Good evening, everybody. My name is Abhishek Deshmukh, one of the electrophysiologists at Mayo Clinic. First of all, we really appreciate all the amazing cases we have been getting and really a lot of excitement and interest in this program. Today, I'm joined by my colleagues, Dr. Amar Kilu, Dr. Chris D. Simone, Dr. Siva Mulpuru, and Dr. Asirvatham. And Dr. Asirvatham will make some introductions and we'll get the session going. Thank you.
Thanks, Abhishek. So we got some nice questions ahead of time, just related centrally to atrial fibrillation. Quite a few of your doubts, questions were either related to complications or post-AF ablation flutters. The flutters we'll handle in a different session in a few weeks. We'll cover some of the questions about complications here as well. I also want to tell you, those of you who sent in cases for discussion or comments, we're a little bit behind. I've gotten back to some of you. We got about another 10 to get back to. We will do that for sure in the next week or so. And feel free to come back and present some updates on those patients as we go along. So I'll cover some of the essential questions that we got from you in this, and just as a short introduction. So first of all, all of us got introduced to atrial fibrillation and at different levels in the evolution of this procedure. But one thing that has stuck through the whole time has been pulmonary vein isolation. And I think really the questions that start arising early in training for someone is, what's the best and safest way to do pulmonary vein isolation? And then a little later, it becomes durability of pulmonary vein isolation. And then after any of us, of you have 200, 300 cases under your belt, the questions then become is, what do we do with failures? What to do when there's back to square one with symptoms and we're having to deal with atrial fibrillation? And that's really reflective of some of the questions that came by. So I'll try to cover a few of these. One of the things that come up is trying to understand what the failure is. Is it an organized arrhythmia or is it AFib? Today, we'll try to focus where it's AFib. It's really the same syndrome the patient had initially. The character has not changed, and we're back to it after we've done our pulmonary vein isolation. And we may have some good evidence at index procedure and after the procedure that the pulmonary vein isolation is actually complete. That could be the scenario, one scenario where we all get questions and some of you have sent in questions. What are some of the things to look at there? So one of the approaches there is, even before rechecking, to get an idea if there are spontaneous initiations of arrhythmia, be it monomorphic or atrial fibrillation. What is that initial beat? What is the initiating beat? This is the concept of recurrent atrial fibrillation mapping. And to illustrate some basic points in this, we're going to keep the catheter, our mapping catheter somewhere, our ablation catheter somewhere, multi-electrode catheters in some key locations like the coronary sinus. And what we look for is sharp signals at a site where we feel the initiation is, and early signals. Both of these are important concepts. The reason they're important concepts is that we know the classic arrhythmogenic substrates, that is the trigger substrate, what is causing the initiation of atrial fibrillation, tends to have these distinct electrograms, and they tend to be contact electrogram late and sharp. If this reverses, then the initiating beat is from there. So two things we're looking at is it early and is it sharp and early, whereas it's not sharp for the initiating beat. So there with the catheter in the left upper vein, we saw it's neither early nor is it sharp. So other thoracic veins that become of interest is like the superior vena cava. Concept is straightforward. We're placing the catheter in that site, and if we are fortunate to see these recurrent syndrome of atrial fibrillation, we look again. Here we see it's sharp, but it's not early. Sharp meaning probably unablated, probably has myocardial sleeve, but that's not the trigger. Here we see a situation where we see a semi-organized rhythm in some parts of the heart with long inter-electrode flat lines, inter-electrogram flat lines, suggesting that it's fairly organized, but some other site which is highly disorganized and rapid. Now, what we won't know from looking at a tracing like this is this an isolated portion, maybe a pulmonary vein that is just fibrillating, but has nothing to do with what's going on elsewhere in the atrium? Or is this the primary driver that's then passively activating the rest of the atrium with variable degrees of organization? So one of the ways to address this, and this is a case from Dr. Deshmukh, I believe, where the multi-electrode catheter was in the posterior wall of the left atrium. So you can keep the catheter there and then see with the subsequent initiation, is this early? Is this sharp? Is it early? Then we notice both phenomena. This much more frequent activations compared to the rest of the atrium during fibrillation, and the initiator is also early. So if that's recognized, then it is possible, if this isn't already part of your construct for initial ablation, to isolate the posterior wall. Similar approach, mapping catheter, late activation in sinus rhythm or a paced rhythm, and then attempt to isolate. And similar endpoints, after isolation, we're losing the signals, no passive activation to that site, and we may have this exit block, ectopy from the posterior wall, maybe catheter induced, maybe spontaneous, but unable to activate the rest of the atrium. So posterior wall treated very much like you would a pulmonary vein. I think it's important to just look historically at like constructs from the surgical literature, that if we treat the pulmonary veins just as the cylindrical veins here, it was in the evolution of the animal studies mitral regurgitation model for atrial fibrillation, not anywhere nearly as effective as when more sites, multiple sites with an isolation type approach were used. So here, multi-electrode catheter, one way to do this isolation of the posterior wall is to connect where the pulmonary veins were previously isolated so that there is no conduction that's possible into this wall. So question then is like, why this posterior wall? Why not this anterior portion? Why not the vestibule? Why not the pectinate muscles, much more complex structures? Why posterior wall, similar to the veins that we isolate? And for there, we should appreciate that anatomically, histologically, embryologically, and electrophysiologically, the posterior wall is the pulmonary vein. So the heart, the atrium is made up of myocardium from the primordial atrium, which is the appendage, the vestibule, which has a multifaceted origin close to the mitral valve, and everything else is the developing pulmonary vein that comes in and merges with the heart. So when thinking about pulmonary vein, there really isn't that much difference when we think about pulmonary vein just as one vein, as a set of veins, or as the true entire pulmonary vein. Several ways to kind of think about doing this. Technically, probably the most difficult, but so-called true pulmonary vein isolation. That is where a lesion set is made, where that whole embryological pulmonary vein is isolated. You could get to that also by connecting the wide area circumferential circles, but you have portions of the pulmonary vein that would still be left unaddressed. That's even more true if you just make really wide circles with a common limb. There would be this as well, but all still getting towards the same thing. Now, another approach is saying that pulmonary vein substrate is probably best addressed by ablating in the pulmonary vein, kill the tissue that's the culprit. But we cannot do that in the pulmonary vein, at least with present technology, because of pulmonary vein stenosis. But we don't worry about that stenosis of the posterior wall. So one approach is just direct ablation of the true pulmonary vein portions, which you don't have to worry about stenosis. But the issues here is the posterior wall, as any of you who are been doing this procedure know, is tough because of structures nearby. Of course, the most feared is the esophagus. Could be simple ulcers, could be simple erosions, and of course, potentially fatal fistula that can occur when we do this. So it limits the approach for how much we can ablate there. Sometimes, though, the esophagus isn't really adjacent to the posterior wall. It's a little bit to one side or the other. But even then, getting portions of the anterior part of the esophagus can be a problem. This is an example of a very large stomach shadow here with food contents from days staying inside the stomach in a patient who had an AFib ablation procedure. And the issue there is the vagus nerve. So the vagus nerve, although it runs to the side of the esophagus, has got this rich type of plexus that interdigitates with each other and includes the anterior wall. Notice this interdigitation has got these looping type filaments. So they go more lateral to where the esophagus is. So even if we're not directly in front of the esophagus, the posterior wall, that could be a problem. Should also remember every time that we are isolating the whole posterior wall, we are by definition setting up an isthmus, because we know the mitral annulus cannot conduct. And now if we have a perfect posterior boundary that's created, we have to for sure then think about the propensity for macro reentrant tachycardias. Now, the other issue beyond macro reentrant tachycardias is myocardial triggers. So this is an example also, I believe, from Abhishek, where a patient with same syndrome of recurrent arrhythmia, but here with the mapping catheter placed in the myocardial appendage, can cause these triggers. And in that situation, it is possible to ablate so as to eliminate the arrhythmia without isolation of the appendage. Presumably, these are types of flutters that include the ostium of the appendage for part of its slow zone. For others, where it is truly a trigger from inside the appendage, then we have the left atrial appendage treated like a vein, mapped, late activation, making sure that the signals that are being seen aren't actually the pulmonary vein. Very important, especially if you see signals that you have interest only in one part of the appendage, and then isolation in a circumferential manner. Some issues when you do this isolation is the mechanical function and technical difficulty with doing it as well. So if we kind of summarize, like maybe tackling a few of the questions that you had brought up, issues is learning about technique of pulmonary vein isolation. But beyond that, it's about durability, and it's about how do you handle it when it doesn't work. And this brief kind of intro here was just some of the things about understanding the recurrent syndrome. Is it new? Then think these are flutters, maybe proarrhythmic. If there's just no change, it may be the pulmonary veins either were not dealt with or simply wasn't the trigger to begin with, and some approaches to consider. So please do send in your questions, and we'll take them as they come. In the interim, I have one question that was sent to me very specific about our approach to avoiding esophageal trauma. So I believe we have Dr. Munger here on as a panelist, or he'll be joining shortly. And maybe I'll start with asking Dr. DeSimone first to kind of tackle that question. What do you think, Chris? Do we have a way to help prevent appendage esophageal trauma? Is it something in evolution? And then maybe I'll ask Amar to also comment about both surgical and endocardial procedures and appendage trauma. Chris DeSimone?
So I don't think there's a 100% foolproof way. So I think we got to be very, very vigilant, especially when I'm on the posterior wall, even if I'm on the superior inferior. I always have an esophageal probe, and I move it continuously every time I'm walking down my WACA line. So I'm monitoring for esophageal temperatures. And if I need to stop, let the esophagus cool down so I don't stack the lesion, that's one approach. If I need to go to the anterior wall and come back, that's my second approach. Third approach, if I can't do it, and usually it's not the first time, but if I know I ran into it and it's a redo procedure, or if I get clues from the CT that the esophagus is really big or right where I need to go, I've also been using an esophageal deviation approach to just get it out of the way so that then I feel much more confident I still have the temperature probe down there regardless. I think the fourth thing is I don't use too high of voltage or power on the posterior wall. So I never go above 25 watts, and I try to keep my lesions 30 seconds or less.
So maybe I'll come back a little later to Amar's comments. There's a question about why we don't have bleeding at the time of the procedure when we get esophageal fistula. And maybe I'll just address that here, and then we'll take a couple of the other questions. So, if we just a reminder of how this esophageal fistula occurs. This is the left atrial posterior wall. And to just remind everyone, we have this little sleeve of pericardium here, which is the recess behind the atrium, the oblique sinus. So one of the things that made it difficult in the early days to know what was going on is this temporal sequence of fistula. It doesn't happen at the time of the procedure. And what appears to be the case, it's heat-related trauma that produces some esophageal erosion. That's all that's happened at the time of the procedure. The fistula doesn't exist at the time of the procedure. This then becomes an ulcer. The ulcer then has erosion, and this already weakened tissue here that can cause esophageal air and contents to get into the pericardial space. This is the stage of the pneumopericardium, chest pain, non-specific symptoms. And then with continued erosion, it actually becomes the fistula. And there we have the endocarditis, we have air in the circulation. Every time you swallow, something is going to the brain, and an extremely emergent situation to try to get rid of. So that's why you don't see like perforation and bleeding at the time of the procedure, because it's not a perforation. It's the inside out. It's coming from the esophagus to then reach the heart. So we have a question that I'd like Dr. Munger to address for us. So Tom, first of all, Dr. Munger is our chair of the Heart Rhythm service, and thanks for joining, Tom.
Thank you, Sam.
So we have a question, and if I understand it right, what it is it looks like it's a question from someone who's new to the field, I think. But basically what it is from experience, what are the aspects of the AFib ablation procedure that have made it easier and safer today that we have to emphasize for new entrants into our field?
Sure. So I think when intracardiac ultrasound was introduced 20 years ago, that improved the safety of the procedure, since you could monitor the pericardium real time for effusion, and you wouldn't have to wait for hypotension to develop before you could identify the presence of effusion and then treat it. Similarly, you can locate the catheter in relationship to the pulmonary vein cuffs. Now that's a little less, I think, an issue now with the new mapping systems as far as giving you detailed anatomy. But I think for new operators, it's still, they tend to oftentimes go into the veins just a little bit when you're doing mapping. And so I think having ultrasound to identify where the catheter is in relationship to the veins and the esophagus and valvular structures is quite helpful. So I think that was one big development, Sam, was ultrasound. I think the contact catheters has also reduced, in my practice, perforation, just because it gives you feedback about high pressures. I think steerable sheaths have helped make the procedure easier to do technically with the RF. So I think those would be the big things that I've seen come along.
Thanks a lot, Tom. And I think also, Tom, fair to say the mapping systems have just created a new visualization approach for trainees.
Yes.
I was doing a case last week with one of our new trainees, and I kind of know the person very well, their strengths, weaknesses, but I was shocked as how well they were doing the venous isolation. Like probably skill level as me 5 years out of training. So I think it's because of that visualization, and then maybe not getting the whole picture, but can feel for here's what we need to kind of go around.
Yeah.
Now we have yes, Tom.
Yeah, I was just going to say, I would agree. It gives you the anatomy, much like the CT, which makes the understanding of the anatomy and where you put the lesions quite a bit easier.
Great. So, we have a question here from Dr. Vasireddy. If I understand right, and please feel free to come up and explain if we got this wrong, but can you use something in the esophagus as a heat sink? So I can just maybe briefly review that issue. It's worthwhile understanding, especially for new folks, for what do we mean by heat sinks, and like how can they be of value? So we know, like, principle of ablation, RF ablation, is the RF itself is not heating the tissue. The radio frequency waves do not cause ablation. They do not cause a lesion or collateral damage. but there's heat that's being generated because of sudden change in impedance at the tissue interface. So this impedance heating occurs here and is going to spread on all sides. Here we have cooling, so it's not much chance to spread into the blood pool. So it's spreading this way and could hit the esophagus. Now, very interesting ideas have been explored to try to minimize this. One of them is to use a cooling device in the esophagus so we can actually keep the esophagus side cool while we're heating this side. And some of the early ones were literally cooling devices. Others have been like porous balloons or porous catheters to kind of create some cooling, much like irrigation on this side. Now, at least in preliminary studies, the early days studies, these weren't of much value. And probably the reason for that is two things happen when we create a heat sink. Is you may actually promote the heat transfer. And the second is the instrumentation and the cooling and irrigation, all of them may add to any damage you didn't see that produces the erosions that start the whole process. So they never really became mainstream. It's with better material design, maybe something worth thinking about. The other interesting idea that was also tried, but I think may have been a misunderstanding of the nature of lesion formation, is using a Bose type technology, the wireless noise cancellation type technology, to say if we take the RF wave and put an inverse wave and just protect from the RF. So you're canceling out the RF to come there, and actually works really great in terms of canceling the wave. But the problem is it's not the wave. It was the heat that was coming there, and it was not possible to show benefit. Now, we also had a question from prior to the session, and I see that Dr. Madhavan has joined us, that maybe I'll ask her to address. And anyone else also, if you see questions, please do jump in and bring them out. So is Dr. Madhavan here online?
Yes, Dr. Asirvatham.
Yes. So Dr. Madhavan is one of our electrophysiologists, special interest in congenital heart disease, device placement, and ablation. So Malini, the question was, how often do we have to manage atrial fibrillation? I think the question was actually structural heart disease, but I'll focus it a little bit more for you on in congenital heart disease. Is congenital heart disease, adult congenital heart disease, atrial ablation, is it all about flutter? Or is fibrillation an issue? And maybe you could share with us some thoughts on which situations is fib becoming more of an issue.
Sure. So focusing on the congenital heart population, traditionally atrial flutter has definitely been a bigger concern, and we see more of the atrial flutter rhythms that are related to surgical scars than atrial fibrillation. So historically speaking, as the surgical techniques started getting better over the course of the past 30 years or so, the initial patients who were repaired when they were younger, we were seeing more of the atrial flutter rhythms. And that is mostly related to surgical scar, mostly in the right atrium. But more recently, the last 10 years or so, both in our practice and also in the literature, there's an increasing recognition that as these patients age, due to the success of the initial surgery and also the success of managing these patients very closely in the congenital clinics, we are seeing more of atrial fibrillation. So at least in the population that we are seeing, by the time patients reach 40 and 50 years of age, we are seeing more atrial fibrillation, particularly if you think about the moderate to high complexity congenital heart diseases. The other place where we are likely to see atrial fibrillation is the ASD population. So patients who have isolated ASDs may also present with atrial fibrillation. And there the question that comes up is, how do you manage the ASD closure in combination
I see.
in combination with management of the atrial fibrillation? Do you ablate first and then think about ASD closure, and questions such as that would come up. But for sure, in the adult congenital population, atrial fibrillation is increasingly recognized. And in fact, just recently, we put together our own experience looking at atrial fibrillation ablation at our center in about 150 patients.
Great. Thanks, Martin. Thanks. So now we have another question that's specifically about vein of Marshall. So, I think it's an anonymous attendee, but asking about vein of Marshall related to atrial fibrillation ablation. So maybe I'll take some opinions here, and then we can feel free, anybody else who has questions in that area, we can look at. Amar, do you want to take a shot at that? Is that a thing, this vein of Marshall? Is it something we address? And your take also from the surgical perspective, where we have direct visualization of the site. Is that something that's part of the paradigm for surgical ablation? Dr. Kilu?
Sure. So thanks for the question. I guess when we're talking about vein of Marshall, sometimes we're also referring empirically to epicardial connections when we're performing pulmonary vein isolation. Sometimes you go around and you do what you think is a perfect Wacker lesion. You check the line, no signal, you pace along the line, no capture, yet sometimes you may still have entrance into the vein, or it can still demonstrate exit. And on some occasions, it's because of these epicardial connections, which I think are becoming increasingly recognized. It's very good to be aware of them. Vein of Marshall, I have not encountered clinically frequently, but I've definitely had other cases where I feel like there has been an epicardial connection either into the carina region, for example, on the right veins, or sometimes actually into the vein itself. And being aware of that, I think is important, because you don't want to just keep going around burning along the Wacker, getting frustrated, risking complications to the patient and whatnot. And so being aware of this, you can do certain maneuvers to try and diagnose that problem. In terms of a surgical approach, again, AFib is generally a very anatomical-based ablation. There are different techniques now surgically that are adopted, taking the open surgical approach out. Some so-called hybrid techniques have been gaining popularity. One example is the convergent ablation, which is a subxiphoid incision, and then a unidirectional 3 centimeter probe is put into the oblique sinus, and complete posterior wall ablation is performed from one vein side to the other. And that can electrically isolate the posterior wall and usually takes care of some of the epicardial connections then. If you do concomitant appendage management, you can actually transect the ligament of Marshall at the same time. And if you put a clip on the appendage, you may actually isolate that as well. So those are just some of the nuances, I think, related to that, if that answers the question.
Yes, I think that's part of the story for sure. Maybe I'll ask Siva also. Siva, we've been hearing quite a bit now for about 3 or 4 years that just empirically trying to target the vein of Marshall, perhaps with alcohol, as part of the AFib ablation paradigm. Your thoughts, your take on this?
Thanks, Sam. So ligament of Marshall targeting with alcohol ablation. In my clinical practice, I've done a few cases in patients with hypertrophic cardiomyopathy. They have a mitral flutter, could never get blocked. both endocardial and through the CS. So those are the patients doing a CS venogram, identifying identifying the vein of Marshall, selectively cannulating it, and inflating a balloon and injecting a little bit of alcohol can take down the myocardium that sometimes cannot be mapped using our current electroanatomic systems. I think there is certainly a role in difficult to terminate mitral flutters, patients with hypertrophic cardiomyopathy. And if you have persistent vein connection and you think that you have a good VACA and it looks like the connection is through the vein of Marshall, those are the situations where I would consider alcohol ablation. But I haven't been doing it routinely.
So maybe I'll just expand on this a little bit here. So, why this vein of Marshall? I think really Amar kind of hit the nail on the head. When we say vein of Marshall, we're really meaning 4 different things. We're meaning trigger, because this vein is a remnant of the left superior vena cava running in this fold between the pulmonary veins and the appendage. And like the right superior vena cava, like the pulmonary vein, this tissue can be a trigger. It's a thoracic vein, just like anything else. We also say vein of Marshall when we're thinking about a conduit. By conduit, I mean muscular conduction from the vein to connect the pulmonary veins to the rest of the atrium via the coronary sinus. So this conduit prevents you from getting isolation of the pulmonary veins. This was a much bigger issue in the early days when we did ablation closer to the vein, but sort of falls away when we ablate in a wide area manner. And I'll explain why that is the case. Conduit also means for flutter. So if this is conducting and we try to do an ablation endocardially, and this is still a way you can get from muscle in the CS to muscle in the atrium, we don't quite get rid of the whole connecting fibers for the flutter and wind up failing with ablation at one targeted site, which otherwise entrainment might have said is great to ablate. The third issue is it is an autonomic structure. So just like the SVC, the right SVC sinus node, there's autonomics in close proximity to the vein, and it's just as true with the left SVC and its remnants. So it becomes an autonomic site. So sometimes to target when you're trying to do an autonomic modulation approach for atrial fibrillation. Just make the action potential duration fundamentally longer for the atrium, so it's much more difficult to get a rapid arrhythmia. And finally, it's just a vantage point to ablate more atrium. So another school of thought is the more tissue you can safely ablate, the less likely is atrial fibrillation is going to recur. So in that case, this becomes a method where if you were to inject alcohol, yes, you get rid of the trigger, yes, you get rid of the conduit, yes, you may modulate the autonomics, but you also have a fairly large area of tissue that you are ablating, and maybe that helps us part of it. So just some background to when we think about what the reason that wide area circumferential ablation, so this is an inside the heart perspective, appendage is here, the forceps is in the pulmonary vein, and this infolding here, which is really where we do our wide area lesion, is exactly opposite the vein of Marshall tissue. So ablation here, just by default, is a vein of Marshall modification. So even though we may not willfully target the structure, we probably do to some extent in most of our cases. Should also keep in mind that It's this ridge along with the way it connects to the coronary sinus, a beautiful dissection from Dr. Damian Sanchez Quintana, that may create difficulty with ablation. In other words, we know if we were to try to draw a line here and we have the CS on the other side, that's competitively cooling the tissue that you're trying to heat and ablate. The same is true if we're doing wide area circumferential ablation around the pulmonary veins and you have a large vein of Marshall or a left SVC. In that site, that will produce competitive cooling. So it may be the cause of difficulty with ablation that forces you to go, in some cases, closer to the vein. We should also keep in mind that there can be distinct signals from vein of Marshall tissue that we could map from adjacent structures. So a catheter in the pulmonary vein, in addition to picking up left atrial signals, appendage signals, and other pulmonary vein signals, could also pick up signals from the vein of Marshall itself. Now, so I see there is a question, and I think Siva, you already answered it a bit, I think, or Abhishek, is in patients who have an ASD, I'm assuming post-closure and atrial fibrillation approaches to trying to do the transeptal puncture. And maybe I'll ask Dr. Munger and Dr. Cha to comment on their approaches, maybe to make it a little more generic, the difficult transeptal puncture, specifically to include patients who have a previous patch closure. So maybe we'll start with you, Tom, your approaches on this, and then I'll ask Young Mei to pipe in as well.
So a couple things about the prior closure with an ASD device. One would be, again, using intracardiac ultrasound or TEE to, and then CT even before you plan the procedure to see if there are windows where you can go that's around the device. Many times you can go on the edges of the device, either posterior, inferior, or anteriorly, and avoid adjacent structures. Sometimes you can go through devices, but I would warn if they're old devices. I had one a few months ago that had been in for 22 years, and I could not go through that device. I think it had been so thick that you just couldn't get through it. For either tough septums or if you really had to go through the device, I suppose the Baylis needle or using RF on a traditional needle would be an approach to get through. And then using either a series of dilators or balloons to balloon or dilate the septum to get the hardware through would be the approach. Ideally, I don't like going through the patches, so I'll go around them if I can.
Thanks, Tom. Young Mei, what about you? Just question is on difficult transeptal. The focus of the question is ASD, but do you want to expand on, like if you think of the very first transeptals you did versus now, what are the things that have made it easier and were more confident in even difficult situations?
I think Dr. Munger has given his experience. I think a key is here is because we use intracardiac ultrasound guidance, so that visualization really helped us, to know the septal anatomy, and then to judge from there, how much force you're going to use, the more anterior or more posterior or superior, inferior. But regardless, sometimes we do have a challenging septals, especially if patients have had multiple ablations, really made the scar around the fossa ovale area. So in that case, sometimes we use, sometimes we use the safe sept. I think that's a very nice set of tools to help us to get into the left atrium. And once we get into the left atrium, sometimes the dilator and the sheath have a difficult time to go in. So it's better to use either C-steps or using the long wire to get into the left atrium and guide it to the pulmonary vein. So in this way, the force, you can use a bigger force, but avoid the dilator or the sheath really perforate the left atrial myocardium.
Thanks, Young Mei. Maybe what I'll do is I'll use a figure to kind of get to what both you and Tom have brought up here. So just a few things. So just a reminder about the interatrial septum. This actually is an important issue for mapping and for ablations in a variety of areas. So a couple of things. So first is you'll notice from this dissection, if we think about septum is a way to go from right side circulation to left side circulation, and there's a curtain separating the two, you'll appreciate that the interatrial septum is actually a very limited structure. Just this little box here, and posteriorly will be the fossa ovalis. That's it. So if we have a large ASD patch, or we have an angel wing device, older device that's closing that fossa and encroaching on this, when we look at approaches, how can we cross? It's kind of pick your poison. What's the problem that you could run into if we want to avoid this? The largest surface area will be above the device, the superior limbus approach. But the thing to remember about the superior limbus is the superior limbus is not part of the septum. It's an invagination. It's separated the right and the left atrium with various amounts of soft tissue and fat. So if you do superior limbus puncture, you can certainly get into the left atrium. The risk would be that if you don't have enough tissue here, extracardiac tissue, that when you pull back, you can get bleeding into the pericardial space. Many of you would have noticed that if you're inadvertently trying to cross and you're thinking, why is it hard, and you're in the superior limbus, when you push contrast, you'll get some staining. It's not a free effusion, but some staining in the epicardium. And that's because there's tissue there that's kind of containing that structure. So one thing that, at least in my practice that I do, so far it hasn't been necessary, but I always do it, is if we are doing superior limbus puncture, like in a patient with a device, I will leave a wire and have one of our colleagues who's very comfortable with plug devices or putting in another closure device, pull the sheath out and then watch for about 30 to 45 minutes on ultrasound to see if there is an effusion that's building up. Should remember that if we do it more anteriorly, we have a small rim, but the minute you come in front of the eustachian ridge, so that is the inferior limbus, then we are risking some damage to conduction tissue. So if patient already has AV block, has a pacemaker, may not be an issue, but that's a risk when we think of an anterior approach. When we think of a posterior approach, then the risk is you may not actually puncture in a way that we're crossing directly from right atrium to left atrium, but we're actually crossing to the pulmonary vein and from the pulmonary vein to the atrium. So this is certainly doable. It's sometimes done inadvertently, and patients have done okay anecdotally. But the problem that you might wind up with is that it's very tough to isolate this vein then to do the wide area lesion, and you may get a small fistula between the pulmonary vein and this. When you go more inferior, then it becomes really like you're entering the CS and then getting in. So just like this is not a true septum, inferiorly also there's separation, but instead of tissue that takes the gap, it's the CS that's taking the gap here. So I hope that kind of gets a little closer to answering that question. So
Sam, I don't know if you want to have a fluoro image just showing the puncture and then the INWI wire. Is that helpful to demonstrate? Just
wonderful. Why don't you talk us through it, Amar?
okay, let me just share my screen. So this was a patient who had a prior ASD closure device and was coming from atrial fibrillation ablation. And the concern was, could we get across? As you had just questioned. And so I'm just going to show you the ICE image.
Maybe
So,
for those not familiar with ICE, do you want to identify the structures for us?
Absolutely, yeah, thank you. So the ICE catheter is in the right atrium, and you see this triangular sector. So the immediate chamber is in the right atrium, and then you can see this big echo density, and that's the ASD closure device. Aorta is just coming in at the 2-3 o'clock position, slightly off axis, and then you can see the left atrium. And often, if we look very carefully, we may find a small rim of tissue that we can puncture. And in this case, I thought there was enough inferiorly that we could safely go across, or at least attempt. Sometimes people do try to go through the device. In this particular device, I didn't think it was possible. It was a very old device. And the other thing to consider is if you are successful in puncturing through it, when you come out, there's a hole that you often will need to close, assuming the indication was solid enough for closure in the first place. So that's the video just to demonstrate that. And then if you can see my fluoro, can you see the PowerPoint now, or is it stopped sharing?
It stopped.
How about now?
Yeah, I think it's coming. Yep, there it is.
Okay. Sorry, two screens is throwing it off. So again, in that case, we were able to go inferior to the device successfully. And then what we use is this INWI wire. And it's basically a wire that as it comes out of the sheath or the dilator, it would just basically loops in on itself. And so that gives you some protection as you're advancing the dilator and sheath into the left atrium. And so we use this not uncommonly in these cases, or at least I like to. And also when we're doing transeptals for left atrial appendage occlusion procedures, just because it gives you that added safety to advance the sheath without worrying as much about going through the back wall.
Fantastic. Amar, do you want to add any comments about like the issue of pericardial patch closure, patient surgical closure? What is our approach for crossing there? You still avoid the patch, go through the patch?
Yeah, again, if I can find a remnant of the true septum, I will always try to go through that first. Pericardial patch, I have gone through before if it was a big closure. Closing it, I haven't done acutely. If there's concerns during follow-up, we can always consider. I always counsel the patient of that possibility, but I haven't had to do it acutely. But puncturing hasn't been as challenging for the most part, but some of them can be very calcified. And so they're the ones that may be more difficult. I don't know what other panelists or colleagues may think.
Yeah, maybe I'll just add a little bit to that. I think the key is what you said is, when we have a closure device, it's always a good idea to see, is there a rim that we can try to go through? But surgical closure for an ASD, they're going to suture to muscle on all sides. So we are not going to get a rim in that case, unless it was just suture for a PFO, in which case it's not a difficult cross. But the point you brought up about calcium is extremely important. So the pericardial patch, especially bovine pericardium over years, one of the risks is it can become like bone. The issue is, I don't think as much that we can't cross it, because I think, sometimes with just brute force, with electrocautery, all kinds of things that we do, we're able to cross, but we have to remember the risk of calcium embolization. So example of a patient who hypertrophic cardiomyopathy, atrial fibrillation, ASD closed early in life, calcified, and actually when we retrospectively look at the cines, you can see calcium there, and then had a multiple embolic episode, the toes, the hands, the liver, the kidneys, acute renal failure, fortunately no stroke, and fortunately a lot of it that improved. But another thing to keep in mind is when we cross and it's hard, is it just fibrosis? Is it just because we have less of landing room? Or is there something that, like calcium, that's formed that we have to be careful about in closing? So I think we're getting close to finishing up.
Sam, there is while we are talking about this ASD transseptal, there's a question about how do we differentiate septal staining versus superior limbus staining when you're in the middle of a procedure?
Okay, sure. So maybe I'll go back to this and we'll just do a very quick one on that. So the key difference is location and movement of the stain. So when we have the fossa itself is staining, you have a sheet that you're using to inject the contrast. So the pressure of that sheet in the LAO view will make the stain move leftward versus rightward. So if you push the catheter, it's just like tenting. That tenting is best observed in the LAO view, and you see it going left back to right as you relax the tension or with breathing or cardiac movement. On the other hand, superior limbus and epicardial tissue staining, it tends to be more widespread and there will be no movement in the LAO view. It'll be fixed because there's no scope for tenting. It's actually this tissue here that's come up to the side and then comes in. Another clue you may get when you have superior staining of the tissue, even though there's no free pericardial, you may see the indentation of the aorta in that area. And that indentation of the aorta with the staining is actually better observed in the RAO view. And the reason for that, maybe I'll show with a different view on the dissection. You can see what's actually filling that area. And what that is when we, in a superior plane, anteriorly, we have this non-coronary sinus of Valsalva pushing into that separated area from the limbus. So you can imagine left side of the limbus here, right side of the limbus here, and this in stern. So if you have staining here, you'll see this outlining of the aorta. That's something you'll never see when you're in the fossa, because the fossa is a more posterior plane to the limbus. Does that answer the question to some extent, Siva?
Yep.
Great. Well, we'll thank everyone. And it's really, once again, the questions and cases that you put together, we'd love to have you come back and put to present to the rest of this. And we'll do this through the rest of the year. We will also make sure that we catch up and respond to your questions and cases. Thank you, everyone.
I think we had some fantastic questions and really timely questions what we encounter in our ablations for atrial fibrillation. One common theme was how do we account for the phrenic nerve and what would be the potential locations or lesion sets by which we can injure the phrenic nerve. Dr. Asirvatham, would you like to answer that?
Sure. So I think unfortunately the physician who asked us this question did have a phrenic injury, and maybe I'll just hit a few high points here. So a couple of things is, naturally we have this right hemidiaphragm a little bit higher than the left because of the liver. And it's something that can be fairly subtle in just the resting state when we have phrenic nerve injury. So few things to keep in mind is it's usually workup of shortness of breath. But it's very different from the shortness of breath with pulmonary vein stenosis. So there it's like cough, shortness of breath, effort intolerance, some hemoptysis. This one is just dyspnea, uncomfortable breathing. And it's worse when they lie down compared to sitting up or standing. Worse when they lie down, but it's not the air hunger of orthopnea. And when you have this weird kind of conscious difficulty, uncomfortable breathing, when the chest x-ray is done, we should ask for a sniff test. So this kind of Muller type maneuver, and then it's very obvious that we're dealing with this phrenic injury. Now, a couple of, I think this is a case of yours, I believe, Abhishek, to kind of illustrate that how the sniff test kind of can bring this up very obviously, or it might be Siva. Just a few things about that phrenic nerve where it gets injured. When you look at the high parts of the phrenic nerve, it's an SVC relationship. So it's SVC ablation. When we think of the lower parts, then it's an equal relation of the right upper pulmonary vein and the SVC. So can be injured, especially balloon, where the balloon is seated little into the pulmonary vein versus ablating in the SVC-RA junction. Now, obese patients are most at risk for being symptomatic. Most reported cases recover if you give it enough time. When it absolutely doesn't recover, then occasional patients, you can do diaphragmatic plication and occasional reports of phrenic injury from other reasons where stimulators, coherent stimulators to try to improve the situation. So that'll be kind of just maybe getting to why it happens, where it happens, and where we need to be particularly careful. I would say balloon, because balloon seating little inside the vein, you have to be careful. Post-op patients, surgical patients, because the strictures from the pericardium, the pericardial fibrosis may move the phrenic nerve, which is a pericardial structure. It's an intraparietal pericardium structure, might move it to a site you're not used to thinking of phrenic nerve. Be careful in those situations there. Does that get to the question, Abhishek?
Yes, I think that's fantastic. We always talk about the right phrenic nerve, but we also need to remember that even sometimes the left phrenic nerve can get ablated, unfortunately. The case you showed about the appendage isolation, we were very careful, especially if you go deeper inside the appendage, we might be getting close to the left-sided phrenic nerve.
Yes, so I think maybe I'll just do a little sketch here, Abhishek. So this is appendage. This is the pulmonary outflow tract. Usually it's 1/3, 2/3 distance on the appendage from the tip is where the phrenic nerve runs. So this is also very close to the anterior lateral coronary vein. That's why basal positions in the anterolateral coronary vein for pacing, we get sometimes phrenic stimulation, whereas it's distal posterolateral vein that we can get the stimulation. Just a couple things about the course of the phrenic nerve as it runs over here is when we're isolating the appendage, that is an issue, but it's also an issue. It's also an advantage in some ways as we're learning more about phrenic stimulation for central sleep apnea, endocardial approaches, venous approaches to try to do the stimulation rather than the present venous or epicardial approaches also come into play for this left phrenic nerve.
Great.
Any other questions we didn't get to today, Abhishek?
Yes, there was another question. Say if you are mapping a flutter and say cycle length is 400 milliseconds or so, and you're not able to account for the entire cycle length both in the right atrium and in the left atrium. So when should we start to think whether the epicardial atrial surface is part of the circuit?
Yeah, so would Siva?
Siva, you want to try that?
Yeah. To take a shot at that?
Yeah, definitely. So first step would be to confirm that the diagnosis is macro reentry. If entrainment shows that it is possibly a large macro reentry circuit and you're missing certain parts of the cycle length. So one thing is to make sure that you have annotated all the points appropriately. Some of the operators don't really annotate fractionated signals. So that may result in not having the full map on your activation map. The second step would be where are the other areas the remaining cycle length could be hiding. It could be septum, ridge between the appendage and the veins, and in some cases, epicardial substrate. And if it is truly a macro reentrant circuit, you can sometimes get away by designing lesion sets to try to interrupt the path. And in patients who you suspected epicardial circuit, then maybe epicardial access and mapping that area is a reasonable option. In my practice, if somebody has a history of prior high power short duration or high power low flow ablation, it can create a substrate where endocardium may be very different compared to the epicardium. In those patients, you can consider upfront epicardial mapping. Does that make sense, Abhishek?
Yes, absolutely.
Maybe I'll just add a few things here, Abhishek. So just using the screen here. So, one of the points that Siva made is we want to be sure that we have mapped both atria, because some tachycardias, large circuit tachycardias, involve both atria, so-called biatrial tachycardias, especially post-MACE patients, for example. This is something you could happen. But this is easier said than done, because we may have part of the circuit here, and then the other part of the circuit could be going away from the septum and back. So if that happens, some parts of the septum actually are not in the circuit. So it would make you think this cannot be biatrial. So just that thorough mapping of both atria sometimes may be needed. Then Siva made a very important point about fractionated signals. So this is a very important issue, and it's a little different, the issue, if you do multi-electrode mapping with minimal annotation or point-to-point mapping with your own annotation. It's a different problem in these two situations. So Siva pointed out that if you're in the habit of doing point-to-point mapping and you found fragmented signals that take up maybe 80 milliseconds, 100 milliseconds of our tachycardia circuit, and if we take that as a location-only point, because we don't know which one to annotate, then it becomes a part of the circuit that necessarily will be missed by the map. So you have to go back and see, what did you take location only without annotation? And if that happens to fill the gap when we look at the width of the fragmented signals, then not only will you get your complete circuit, but you'll have a high degree of suspicion that this is necessary not only to finish your map, but to finish the tachycardia circuit, and would be a good place for doing the ablation. Some operators will take a point, an activation point, arbitrarily as one of these, and note there are fragmented signals. So even then, when you look back at the fragmented signals, if they were not location-only points, you still would need to go back and see what could I take here. For automated systems where there's minimal annotation, this produces a different type of a problem. Because several beats are being mapped, each time you could have taken a different signal, and it will give you a map that's difficult to visualize the circuit, but you'll see crowding of signals at one particular site. Multiple timings, very, very, very close to each other. This doesn't mean the circuit is there. What it means is the equivalent of a fragmented signal site that you need to go back to explore and see, if I did take all of these, would I get the whole tachycardia cycle length? I think the question, Abhishek, you asked is about epicardial. Could it be epicardial? And the answer is yes. But what is epicardial? What is epicardial could be the epicardial myocardium, but it could also be an epicardial structure that forms a bridge between the chambers or parts of the chamber. Notably, we have non-coronary sinus of Valsalva anteriorly and the muscle of the coronary sinus, the true coronary sinus, inferiorly. So there we may need to make a separate map of these structures and add them to the map endocardial to get the full tachycardia circuit. I'm sure we'll tackle some of these issues even more as we move towards macro reentrant tachycardias at a future session.
Great.
Were there other questions as well, Abhishek?
Yes, there was one more question, that it is always difficult to ablate ATAC or PACs with the earliest site, say at CS7-8, near the mitral annulus or near the coronary sinus. How to explain it in anatomy? So at least maybe I'll give one example why sometimes it can be difficult. As you're getting close to the coronary sinus, there can certainly be a heat sink effect, and you may not be able to give a good lesion at that point. Second, it could potentially be a breakthrough point for another flutter which is going on. It is just that you potentially map the early site which is there, and ablating there may not result in termination of the tachycardia. So these are some of the things I would think of, but maybe some of the other, you or any other panelists could answer that more.
Yeah, maybe Chris, do you have some thoughts on this? So I think the doctor is saying that by experience, they've noticed that I think they're talking about like post-AF ablation scenario. There's a atrial tachycardia or PAC that's in the vicinity of CS7-8. And by that, I think what's meant is like posterior posterolateral mitral annular region mapped with a coronary sinus catheter. And it's been really hard to ablate, to get rid of it in that situation. So Abhishek pointed out a few things, the cooling issue, your experience or your thoughts on why it could be difficult in that region.
I think if I'm understanding the question correctly, or what they're trying to get at, I think that region specifically is just really hard to get catheter stability. And maybe that's the reason why they're thinking that it's kind of difficult. So at that region, it's, I rely on ice as much as I can, but it's hard at that vestibule area. Sometimes there's that step off, hard to keep your catheter stable, I think. I'm not sure how that relates into after the ablation of the atrial fibrillation, though. I'm not sure if their catheters just keeps falling off and going into the ventricle, but that would be something I think of.
Yeah, so great thoughts. Maybe I'll just add a few things here. I think this is the region that we're talking about. So CS7-8, something around here. So few kind of things to think about here. First of all, is that a reentrant tachycardia that we mistook to be a automatic tachycardia that we're failing to ablate? In other words, the reason we may have thought this is an automatic tachycardia is because we have a focal breakthrough here, bracketing best as we can see. And it looks like pebble in the pond should be easy ablation, get a catheter there and ablate it. And you pointed out, because of the mitral annulus nearby, this could be tough for stability. And I think Abhishek pointed out, it's the CS that's cooling and making it tough to get a transmural lesion there. But I think another thing to be very cautious about is the CS and the left atrium are not always telling us the same story. So we may have the large atrial electrograms showing us that there is indeed a focal type breakthrough. But this may be the exit site for a tachycardia that's using the CS as a way of completing the circuit. So it's kind of like a mitral isthmus type tachycardia, but the mitral isthmus may look blocked and this may look like it's bracketed, but that's just the CS to LA connection in that location. I can draw an analogy to an epicardial accessory pathway that uses the CS, but the way it gets to the left atrium might be at this site, and we could ablate all day and you never get rid of it. So if we have really a reentrant tachycardia and you ablate here, then it's just going to maybe still complete the loop through here and you just never get to it. So one step there is to define, is it automatic or reentry? This gets even harder when it's PACs, if these PACs are just single beats of reentry. So there I kind of fall back on the clinical story. Is this like an automatic PAC, automatic tachycardia patient scenario? Or is this a reentrant patient scenario? Meaning